Hi, this is Dr. Tom Murtaugh of the Christ Hospital in Cincinnati, Ohio, presenting highlights from a recent webinar on behalf of the International Cardio-Oncology Society. The webinar focuses on the diagnosis of atherosclerosis in the oncology patient. Our presentation comes to us from Dr. Zsofia Drobni. Dr. Drobni is a Cardiology Fellow at the Semmelweis University in Hungary. She is also the founder and president of the Hungarian Chapter of IC-OS and was previously a research fellow at the Massachusetts General Hospital in Boston, Massachusetts. I know you will learn a lot from the following presentation.
But let me just start with a case from last week. Actually, I'm working as a cardiology fellow, and every week I spend one day in the CT and one day in the MRI. And it started working out that I get cardio-oncology referrals for CT and MRI. So last week, one of my colleagues from another department called me about this female patient with stage 4 melanoma who received several cycles of nivolumab between 2020 and 2023. Then in 23 April, she progressed, so combination therapy was started. But again, after a year, she progressed again, and this time they wanted to start pembrolizumab and lenvatinib, and this was the reason why they referred her to my cardiologist colleague, and he started to do the checkup. And then this ECG came up. This was a new finding because they looked at the previous ECGs of her, and those were completely normal. But I'm pretty sure all of you know what we see on this, but I just want to make sure. In the inferior leads, we see negative T waves and very deep T waves from V4 until V6. So now I get the referral for cardiac MRI because my colleague thought that this ECG and also the echo is typical for apical HCM. But it's very odd that the ECG 1 year prior was completely normal. So we were thinking about MRI to figure out what's going on in the apex, but we didn't have a slot. It was not a very urgent examination. And then I thought that, okay, let's just look at the CTs that she had previously, like every 3 months, and let's see if we can see any hypertrophy or anything in the apex. So we got lucky because all of her staging and restaging scans were performed in our hospital. And as you can see, last year in May, we don't see anything in the myocardium. I know that this is a non-gated CT scan, but as you can see, we actually can see a lot of things on these scans. The walls seem normal. Okay, then next year, when she progressed, this was the CT where they decided that they would start pembro and lenvatinib. We can already see that something is going on in the apex. Here you can see that there is some hypodensity. Of course, it was not mentioned in the radiology report. So then we called up the radiologist to whether he or she wants to reevaluate the report and whether wants to add anything or not. And then this was done a few days after. So the radiologist said that, yeah, okay, we think this can be a thrombi or an intramyocardial propagation of the melanoma itself. So I think that the main message of this case is that putting it all together, the ECG, the new ECG findings, And all the images that we already had on this patient, we did not perform the MRI because we are pretty sure that this is not HCM and this is not a thrombi, but this is an intramyocardial lesion of the melanoma itself. So this is an intracardiac metastasis of melanoma. And I think that with this approach by cardiologists being familiar and being okay with checking the CTs, we can do a lot and we can avoid unnecessary examinations. And with this, we also saved a lot of time because we did not have to wait for the cardiac MRI slot. So let's just go through quickly what we can see on all of these staging and restaging CT scans that patients have every 3 months. So it's usually a chest, abdomen, pelvic is scanned. They do a non-contrast and usually venous phases and arterial phases. It's very important that arterial phases are not the same as NGOs, and we don't have NGO ECG gating and dedicated softwares available for reading these staging CTs. On the contrary, if we do a proper cardiac CT NGO, it's only a small field of view, so we only focus on the heart and the coronaries. We do a non-contrast for measuring calcium score, and we also do an NGO, which is ECG gated. These are different protocols, but as the previous example also showed, we can assess calcification, dilation, and filling defects on the staging CTs also, which are very useful. This is a very nice paper on actually what do we see on the staging CTs from a cardiologist's point of view. And you can see that actually there are a lot of relevant cardiovascular findings. So when they looked at 5,000 patients staging CT scans, they found more than 300 relevant findings. And the majority of these were, of course, venous thromboembolisms, but they were also able to see some cardiac thrombi. I just want to emphasize that even I think in every country, not just in Hungary, but general radiologists are not that confident with reading the heart. As you can, as I've shown on the first example, they just don't look at the heart. They don't really care about it. They don't really know how many important things there can be which do have clinical relevance, just like that intracardiac metastasis. But in this case, this was probably a metastasis, but otherwise it could have been a thrombi also, which would have other relevant clinical decisions. We also know that from the cardio-oncology point of view, there are a lot of roles for cardiac CTs, and it's becoming a very important diagnostic tool to answer many questions. It's important before, during, and also after cancer therapy. We mainly use it for coronary artery disease to rule out the disease, and very rarely we also do it for pericardial diseases. With cardiac CT, we have a dedicated protocol with a lot of heart rate optimization, with giving sublingual nitrate, and also finding the perfect time for starting the contrast. As Dr. Polensky already mentioned, coronary calcification is very important. There are a lot of papers in it, so I will just skip it and emphasize that also the SCCT, the Society for Cardiac CT, also mentions that every CT and PET CT scans which are done in cancer patients should report at least the presence or absence of coronary calcification. And we have to aim to provide a coronary calcium score for these scans. Now I would walk you through like how do we actually do the plaque quantifications, which plaque quantification is not part of the clinical routine, but is part of all the scientific papers, especially on what I've been working at when we looked at plaque quantification with immune checkpoint inhibitors. So basically, we can differentiate three main plaque types based on calcium content. If the plaque is fully calcified, it's a calcified one. If it has some calcified and some non-calcified components, it's partially calcified. And then here I show you a non-calcified plaque. And these plaques are usually high-risk plaques which are prone to rupture. The red circle shows the lumen, and the green circle shows the vessel wall. So whatever is in between, that's the plaque. And with dedicated softwares, we can quantify actually the plaque volume. And based on densities, CT densities, the software can differentiate between plaque components. We can set the threshold because thresholds do change based on how based on your scan protocol, like how much kV, mass, what type of contrast you use. So you will have to set up your own protocol and your own cutoffs for necrotic core or fibrofatty, fibrous, and calcified components. But basically, this is the approach we use. Here I'm showing you a right coronary artery, and this protocol is for coronary plaque calcification. But since in cancer patients we only have a ton of staging and restaging CTs, we are not using coronaries, but we are using aortic plaques, and we do aortic plaque quantifications. Just like we did on this paper in a cohort of melanoma patients, we searched for those patients with melanoma who were treated with an ICI and had at least 3 abdominal CT angios available. We picked one CT which was at least 3 months prior to the ICI start, another one when ICI was started, and the last one was picked at least a year after ICI start. And just as I've already shown you, we circled the lumen, and then we circled the vessel wall, and whatever was in between, the software did quantify it for us. And then we compared the change from 3 months prior to change to ICI start. So this change was compared to this change. And this way we were able to see what effect does ICI therapy has on plaque progression. And what we found in this melanoma cohort is that total plaque volume did increase 3 times after patients were started on an ICI. This change was 2% per year, and here we observed more than 6% increase per year after patients started ICI. But as you all know, patients with melanoma are not as high-risk patients from a cardiologist's point of view as patients with lung cancer. So as a next study, we basically repeated the same study, but now we used patients with lung cancer. And we found something very similar, but in this case, we not only used cases, so patients who received ICI and 3 time point scans, but we used patients who received ICI before and after CTs, and we added some control patients. So lung cancer patients with 2 CT scans, but who did not receive ICI therapy. And when we looked at these plaque volume data, we found that patients who received ICI therapy had a higher rate of non-calcified plaque progression as compared to those lung cancer patients who received something else than ICI, because in these patients, calcified plaque progression was much more pronounced than in the ICI cohort. And I would like to show you this the last line, because we were also able to look at patients who received combination ICI therapy, so dual ICI therapy, and those patients did have the highest progression rate of non-calcified plaque components when compared to patients who received mono ICI therapy or who received something else. And I would also like to briefly mention the role of PET-CT in imaging atherosclerosis and imaging inflammation, because patients also undergo a lot of PET-CTs, and this is also a lot of imaging data that we have available. We just have to use it. In this very nice paper, they also showed that there is an increase after starting ICI therapy in plaque inflammation, which can be visualized by PET-CTs. And I just want to briefly mention ICI myocarditis. This is a very challenging diagnosis, and as you can see, an exclusion of acute coronary syndrome is mentioned in the guideline. But in the daily clinical practice, I find a lot of challenging cases when we talk about patients who have a slight troponin elevation and they don't really have any symptoms. How should we start the workup towards ICI myocarditis? When is it when we have to perform invasive coronary angio to exclude the acute coronary syndrome? Is there a role for cardiac CT? And I do think that there is a role for cardiac CT, but it is very difficult to perform because the wait list is usually in our center at least 4 or 5 months for a cardiac CT slot, and I'm pretty sure it's very similar everywhere. So what we came up with is a dedicated protocol where we insert a cardiac scan into the restaging of the patient. So every 3 months, these patients do go for restaging CTs. They get contrast agent, and our very nice radiologist colleagues were able to make a protocol which is very similar to the triple rule-out protocol. You can see that there is still a lot of contrast in the right side, so it's very similar to the triple rule-out. But this way, they are still able to do whatever they need for the staging CT, and in between, they just quickly do a quick cardiac scan. This way, we don't have to wait for the cardiac CT slot. The patient is already in the CT scanner. We just have to put on the ECG leads, pay attention for reducing heart rate or like putting heart rate around 60. And it's a tiny bit of extra radiation, but we are not giving contrast twice. So I think this can be a very good solution for patients who have slightly elevated troponin, or in this case, this was performed for a patient with esophageal cancer, where they wanted to rule out coronary artery disease prior to surgery. So I think that by working together with the radiologist, we can really optimize patient workup and patient flow. And I would like to mention just the future perspectives. And we can really see that with the new softwares and the new scanning methods, radiology will will just go crazy because they can measure so many things with all these AI-based methods that even on non-contrast scans, we can get cardiac dimensions and cardiac score, calcium score, and also aortic dimensions within seconds after loading the images. So as a summary, I would like to emphasize that as a cardiologist, we have to be confident in looking at CT images, and whenever there is a clinical question, we should not hesitate to check the CT images retrospectively. There are so many cardiovascular information available on those scans, and that, as it has already been mentioned in detail, calcium score is very, very important. And there is just one question I want to put out there, maybe for this discussion, is whether there is a role for CT angio after we did quantify calcium score. So should we rule out obstructive coronary artery disease in patients with a high calcium score or not? Or is it enough that we know that the calcium score is high and we start statin and maybe aspirin if it's over 1,000? I also suggest that ruling out coronary artery disease, especially in patients with pre-surgery or with asymptomatic troponin elevation, coronary artery CT within the staging CT is an optimal timing. And we have to work together with radiologists, and we have to be confident in reading the CT scans. Thank you for your attention.
It was certainly great to hear a presentation of the utmost importance to cancer patients, especially disease survivors. You can find out more about all things related to cardio-oncology by visiting the ICOS website at ic-os.org. Don't forget to join with the Cardio-Oncology community at the GCOS Summit in Minneapolis, Minnesota this September 2024. If you are not a member of ICOS, please consider joining, and don't forget to treat cancer, protect hearts.